All right, here we have Pistol. She's 17 or 18-year-old mare. Last year had a bad injury to her suspensory ligament up here that we've been shockwaving, laser, rehabbing. She's had a ProStride injection. Today we're going to do a recheck using the Equinosis. Uses Bluetooth inertial sensors to monitor her asymmetry. We'll get a baseline on that. We plan on shockwaving her and doing a regional limb perfusion with the Regeneflex. So Autumn's going to strap her up now with the sensors. She's going to put one on her hip on the very middle and the highest part. And this one's going to measure the rise and fall of the pelvis with every stride. It's going to tell us how hard she's landed on each leg and how hard she's pushing off, and compare the two and give us actual numbers. She'll also get one on her right front leg. That's a gyroscope. As long as she's trotting, that tells us which foot is on the ground and when and what part of the stride. And she'll get a nice little bonnet that has a sensor that's going to measure her head nod, basically. Horses can use their head to get away from pain. So we'll strap her up. We got her in the tablet. Autumn's a certified Equinosis technician. So she's going to put it at the highest point on her hip, right in the very middle. And we'll clip it on so it doesn't fall off. And we'll use a little elasticon. It's summer and they're flies and they'll swish their tail and catch the clip. So this keeps them from ripping the sensor off that way. We use the right front, and all that one does is tell us which foot's on the ground. Pistol's no stranger to this, as we've been monitoring her progress with all the treatments. A lot of people ask if this makes any difference in the way they move, and it doesn't. We can still do all our flexions and everything like that on that leg. It doesn't change a thing. So her original injury is up here at the origin of the suspensory ligament. So we'll ultrasound it here in a little bit and see how it's healing. The sensor on her head, we use this little bonnet and strap it to her halter. A horse's head is a massive amount of weight. So it's like a big weight on a lever, and they can use it to get away from the pain. Like if you go on your bathroom scale and throw your hands up, you weigh less, and that's how they use their head to get away from pain. And the cool thing about this is they tell us what part of the stride they're actually trying to get away from the pain, whether when they're landing, the mid stance, or the push off when that front leg's behind them. And it's interesting the way the front end changes based on hind limb stuff. We'll probably see that today in the report. So she's all strapped in and ready to roll. So on the tablet, we can select our surface, whether we're in soft, grass, asphalt, whether we're straight line, lunging, and everything like that. So it's great for tracking horses like this with rehab, because we can't, oh, I think he's a little better. No, this gives us actual numbers and percentage improvement, so we can see how our treatment's working on horses like this. I think you can probably just trot her. All right, we're connected, Jenny. So we'll take a couple, because horses that are a little stiff out of a stall, they can warm out of a lameness. So if you just trot one and you go to block, and you know, is your block working or is the horse just improving on its own? So we usually get a couple until we know the asymmetry is normalized. So we're rolling, Jenny. We'll get another one. Autumn will give her a little encouragement. Way better. She's way. All right, let's get one in the grass and see how that compares. We actually got a little rain last night, so our grass isn't as hard as concrete. We'll go right over here, Jenny. All right, we're rolling. Crack, sweet. Told Hannah yesterday when she spilled. Oh my God, Hannah. So a lot of people ask, oh, that tells you where they're lame, and it doesn't. It helps us identify the leg and which part of the stride, and whether it's push off or impact, which helps guides us on blocks and everything, but it doesn't tell us it's hocks or stifles or whatever. It doesn't really replace the veterinarian. Now we're going to get 8 strides, and that's used as our baseline before we flex them. So we'll get these 8 strides and then flex her and see how it compares. So we'll get her 8 real quick, Jenny. So with this, we'll put in what leg reflection and what test we're doing, and it'll pull up the results side by side. So left hind limb, proximal limb. Hit that button when it pops up. Perfect. Good job, girl. Square her up just a little, Jenny. There we go. With the hock flexions or proximal limb flexions, the sensors will tell us how hard they're landing and pushing off afterwards. So it helps guide us whether we think it's bone pain in the hocks or soft tissue back here or stifle. We're not just flexing the hocks, we're stretching this back here, and we're also getting a little flexion in that stifle. We won't hold her too long. Okay, Jenny, let's try her. Still pretty sore. And for the purpose of this, that's all we really need today. In a normal Lameness exam, we'd do every joint and record everything here. So we'll take her inside and put the ultrasound on there and see how that ligament's looking. So here's a couple of reports we get. We can compare different trials. This is the asphalt and this is the grass and turf, which is a little bit softer. You can see she's pushing off a little less hard on that left hind limb in the grass versus the asphalt. And then this one is our Flexion. So these are the 8 strides we got first. You can see the first few strides a little sore, then she kind of levels back out. This was after we flexed her. Now she's off the charts on the push-off. The cool thing with ones like this is you can see she's still landing just about as hard. So if we were working up this horse for a lameness exam, that would clue us from, you know, it's probably not the hocks, it's maybe more soft tissue or stifle or flexion, which that guides us for our next diagnostics like blocks and everything. So what we're going to do now, since we already know where the problem's at, we're going to clean that leg really good and prepare it. We'll stick the ultrasound on there and get some good images and see how she's doing with the healing process. This was a really bad injury. We've been treating with shockwave and laser and everything for the past several months. And she has improved quite a bit, especially on the asphalt, but we've still got a ways to go. So we're gonna treat her with shockwave today and then do a regional limb perfusion with Regeneflex, which we'll explain when we get to that point. So we'll tie up her tail, keep it out of my way, and keep the lube from getting on there. The thing about ultrasound is getting your site super clean. Usually we shave her hair so short now we can probably get good pictures without having to shave it. So the suspensory ligament starts up here just below the hock, and its ligaments are bone to bone. So it comes off of that bone as one body, and then it splits into 2 down here on and hooks on the sesamoids, and it helps. It's called the suspensory ligament because it helps suspend the leg. And when these muscles get tired and these tendons get tired, that's when it really takes over. So a lot of these horses that have these injuries, they usually happen at the end of a trail ride or after a long weekend of using them hard, when that ligament just gives out, especially these ones that are older. And let's hit the lights on them. Is that okay with you, John? And I'll try to turn this where you can see it. So we're going to use ultrasound, which uses ultrasound waves to send out a signal, and then they bounce back to the transducer, and that's what gives us our image. So here's our flexor tendons. That's a big blood vessel there, I think. You can kind of see the blood flow in there. Get just right on it. Just push on her hip a little, Jenny. So here is her actual suspensory ligament. When we first started, it was barely recognizable. So you can see some of it, that bright stuff, is where it's been healing, and the fibers just aren't running as perpendicular. So we're getting a little increased signal there. And then there's still some areas of what we call hypoechoic, where it's darker, where we're not getting as much sound back. So we'll save a few of these. We're looking at it in cross-sectional now, so we're taking little millimeter slices and looking at it. We'll flip the probe here in a minute and go parallel with those fibers and see how it looks. And you can actually see where it attaches to the bone. But a lot of this in here is a little irregular. There's still a little bit of hypoechoic area there. Water or air shows up, or fluid or air shows up black on here because it doesn't bounce back as hard. So where the fibers are disrupted, we're not getting that signal. That's why it's showing up black. And the products we use to inject these, you can inject right into the ligament, but since this is more chronic, we're going to do the regional limb perfusion and kind of treat the whole area. Her circulation will take the product where it needs to go, especially after we shockwave her. So we'll flip now and go parallel to these fibers. So here's her cannon bone, and these are her tendons up there, and this is her ligament. You can actually see where it comes off of the bone there. And what we can note in this one, some irregularities along that bone at its insertion. There's a little probably osteophyte there, and that bone's remodeled. What we like to see is a nice thin line through there. And then ideally with the ligament, you'd see fibers running that way. Now the suspensory ligament, it changes over time with these horses, but you can see the difference up here where her injury was versus down here where the fibers start showing up, actually running. So she is much improved from the original injury. We couldn't even hardly press on this leg to get a good picture. But all these little areas of black are irregular. So ultrasound tells us a lot. Unfortunately, it doesn't tell us how strong the tendon or ligament is. So we have come a long way with her injury, but we still got a ways to go. You can see some scar tissue there, fibrotic areas that's giving us a bigger signal. Okay, those will be good. She doesn't like her tail wrap. Okay, so here's one from last November. This is that ligament we just looked at. You can see how much bigger it is, and all that black in there is abnormal. So all these little holes. There's our splint bones, and we like it to be in between them, but with hers, it wasn't. She had a pretty severe injury. So everything we've done so far is helping. We're going to try to encourage some more healing. If we can get those fibers to line up better as she heals, she'll be stronger and last longer down the road. Was a hole in that suspensory. So it was pretty trash to start with. So the first thing we're going to do is shockwave that area using the PulseVet shockwave system. Jenny can go ahead and set it up. Shockwave uses a high voltage spark plug to evaporate fluid and generate a sound wave. There's nothing electrical going to hit her leg. It's just going to be an acoustic sound wave, and there's going to be a rapid increase and decrease in energy. And what that's going to do in a nutshell is kind of essentially trick her body into thinking she just re-injured that area without actually hurting anything. So it recruits stem cells, fibroblasts, the stuff that heals tendons. We'll get new blood vessels and everything like that. And it'll also help break down some of the scar tissue and adhesions that are forming during her healing process. So here's all the different trodes, we call them. With this one, we're going to use 2 different depths and kind of come from different angles to treat that whole area. They've got this figured out where they can control it, where it's not scattered, where it goes where you point it, and we can control the depth. And for injuries like this stuff is awesome. So there's all different energy settings as well on the shockwave. It goes all the way up to energy 6. I usually make sure the horse is nice and sedated and crank it up. The more power, the better. And you can control the pulses per minute up to 360 per minute, which is a lot. And so what some of the human research or studies have taught us, since humans can actually tell us afterwards, like, yeah, I feel better. They found that 180 to 240 pulses a minute is ideal. So we've kind of adapted to that. We'll probably treat her at 180 to 240 pulses per minute, and we'll give her a total of 1,500 pulses. So Jenny hooked up the 35 millimeter one, runs a little self-test. Make sure everything's working right before we start. And then Jenny's gonna shake that probe, and that's gonna disperse all the stuff they've got in that fluid. That way the first few pulses work good. So we will, you're gonna do what, 500 or 1,000 with that one?
500.
So there's our selected dose. We're happy with that. We'll go down and change the pulses per minute. We'll jump up to 240. And then I'm gonna reset the pulses and it'll monitor. And then we'll also crank that energy setting up to 6. The other important thing with the Shockwave is lots of lube. And her leg's already clean from the ultrasound, so she's good there. Oh, she liked her drugs. We give them a mix of sedation and butorphanol, which is kind of pain control. With the soft tissue stuff, after the first initial pulses, it kind of feels like a massage to them, and it kind of numbs them for a little while too. You can also see how much she's dropping on this one. See how low her ankle's getting. A lot of older horses, that suspensory ligament will degenerate and it just gets weaker and it'll drop over time. She's not as bad as it. She's better when she's not sedated, but we have noticed her ankle's dropping a little with this injury, just as that suspensory is not as strong as it was. Well, maybe one more step on him. Can you do it, Pistol? There we go. Jenny will position herself in a safe spot just in case she does react a little bit, but she shouldn't with the drug she has on board. And this is just a little hand switch that turns the machine on and off. And it is a little bit loud. There's going to be a lot of clicking here in a minute. So there was 1,000, we'll switch, or 500, we'll switch probes and hit her from the sides too. We use Shockwave for all kinds of things. Fractures, wounds, tendons and ligaments, soft tissue, it works awesome. It speeds up our healing time and it also improves the quality of the healing. So where horses will fix themselves over time, those fibers may not line up like we want them, but this encourages those to line up better. And the better they line up, the stronger that tendon or ligament's going to be after treatment. So if you go to PulseVet's website, they've got a locator of vets that have it available. You can find one in your area if you're interested for treatment on your horse. One of the reasons we'll Shockwave before the Regeneflex is to kind of cause a little bit of micro trauma to that area. And then when we put the product in the vein, circulation is going to take it to that area that's inflamed. With other orthobiologics like PRP or Prostride, we Shockwave afterwards because it activates some growth factors in there. But for this particular thing, we prefer shockwaving ahead of time. So it's going to make our product work better, and she gets the benefit of the treatment as well at the same time. So she's going to hopefully kind of get her to stand her weight off of that, and what she can do is scoot these tendons over a little and then use the probe that goes less deep and hit it that way too. It's a relatively big structure we're hitting, so we kind of hit it from all angles and depths. She's had several of these treatments the past 6 to 8 months. So we've hit that ligament from the back with the deep probe, and now we're going to hit it from each side with the shorter depth, and hit it from all angles. And that's got her 1,500 pulses. As you can see, they tolerate it really good, especially when they're a little sedated like that. So our next step, we're gonna do what's called a regional limb perfusion. And we use this for all kinds of things. Injuries, we can put antibiotics in the perfusion. We're gonna you put a tourniquet on at least above where the problem is, whether it's an injury like this or a wound, or we're treating a lot of horses that step on nails, we do this. We'll put the tourniquet on above it. You could put one below it if she had a wound here. You could put one below it to concentrate it. With hers, since this whole ligament's probably affected, I'm just going to put the tourniquet up here and let the whole leg get treated. Most of it will go to where that injury is, especially since we shockwaved it first. So we'll hit this inside vein over here. And when you do these regionals, especially with antibiotics, it'll concentrate what you inject up to 100 times in this area versus giving them an IV dose or anything else. And like I said, and we did it when it first happened, you can inject the actual injury with this stuff. Since it's filled in, we don't have a big hole that we need to treat, we choose to do a regional. And then it'll concentrate in here, but we'll treat kind of everything. And this product's made from amnion, so there's all kinds of growth factors, anti-inflammatories, and it's going to give her the building blocks to help keep repairing that thing. And there's also a bunch of exosomes, which kind of like carrier pigeons. They're going to tell her body, like, hey, we need more stem cells here, we need fibroblasts, we need stuff to help fix this area. That's the theory behind that. And we have great success with it. So we can wipe that lube off. And then I'll hit her probably right up here. I don't know which one would be, or maybe probably this one. Yeah, so just scrub down here.
You want me to clip it?
A real small spot. No, don't clip it. Should be fine. Regeneflex RT. So it's a powderized product in here that will reconstitute and then make it a little bit more diluted. That way it can fill up the vasculature. We'll mix it up first and then get the leg ready, then inject. We'll get some sterile saline. And there's our amnion. You can watch it dissolve. This product dissolves really good, really quick. Mix it up a little. And then we'll dilute it out for the regional. this in there. Then she does not like her tail wrap, does she? We'll dilute it even more. The great thing about products like this is they're right off the shelf and we get a consistent product to inject versus if we reach for PRP or anything like that, which we still use. But so we'll use our tourniquet, a butterfly catheter. Jenny has got the site sterilely prepped for the injection. And we'll put the tourniquet on and get this thing a-cooking. We'll rewrap her tail again. Horses usually don't like tourniquets, but she's sedated enough, and then I use this to kind of fill in the dead spot here. You want to grab that elasticon, yeah. This is the world's longest tourniquet. Yeah, if she can. Perfect. Okay. It'll slip down a little, so we'll go high. Just like wrapping a limb, I'm going to put most of the pressure on the front here where the muscles are and try to avoid too much pressure on the back. I mean, she's going to get it, but it'll only be on there for 30 minutes max, and we'll let the regional, what I like to call cook, for about 20 minutes. She's a good patient, so she should tolerate this pretty good. We've never done this on her, but the guy that bought her originally a couple of years ago brought her in for a pre-purchase. After we messed with her, I told her, if you ever sell her, call me first. So she's now mine for my 5-year-old daughter. She's one of the sweetest patients we've ever had. She's got the tourniquet on. I'm just using a little elasticon to hold it in place so it doesn't slip and doesn't unravel. This is the most important part. Make us a tag so we can take that thing off when we're done. Yeah, if you want to go ahead and wipe. You got your Band-Aid ready? We'll make sure our product's nice and diluted, dissolved. So we'll use what's called a butterfly catheter, which the needle's here, then there's a flexible tubing, so I can stand on the other side and hit it and kind of safely move if she moves her leg or anything, and then we'll attach this to it and inject it into the vein. Does she stand on it? All right, pistol, a little poke.
Good girl. Oh, baby.
We'll let that blood fill up, then we'll inject it. It's a small needle, so it takes it a second. Then you can see your vein fill up, and sometimes the vein will swell a little. We're going to put a Band-Aid on right after it with a little diclofenac, which is an NSAID cream, and it usually keeps the vein from blowing afterwards. I'll put it in relatively slowly to try to keep that vein from blowing. If I let off pressure on the syringe, you can see a little blood come up there. You can see it come back a little. I'll do that periodically to make sure we're still in the right place, but you can actually see the whole vein filling up there. Got your Band-Aid ready, Jenny? Okay. Now we'll pull the needle and put a little Band-Aid on there and set a timer for 20 minutes, and then we'll take the tourniquet off and we'll wrap that leg to kind of prevent some swelling afterwards, which we usually wrap after Shockwave anyways. So we'll let this cook for 20 minutes and she can go back to the rest of her day. Oh, you did? All right, the regional is over. So we'll take this tourniquet off. We've reached our 20 minutes. Her leg can go back to having feeling again. Take the Band-Aid off. I can find Jenny's tag. Autumn, you got scissors handy?
Yes, sir.
Oh, yeah, I'll just cut it to be easier. All right, now we're going to wrap this leg. We usually wrap after Shockwave anyways, kind of prevent some swelling afterwards, and especially after having a tourniquet and stuff put in there. So I'm going to pass the mic to Autumn and she can explain her beautiful leg wrapping technique and why we do what we do when we wrap legs, whether it's a hind foot or a back foot, right?
Correct. So right now I'm kind of just, we had some lube on there earlier. I'm making sure that most all that's wiped off while we've got this wrap on there. We use, they're called Ready Rolls. Really nice, already pre-packaged. So on any leg you want to wrap front to back.
She's tricky.
And you always want to pull tight around the front. Her injury is a little further up, so I'm going to take, this isn't quite long enough just to get up here, so I'm going to take and kind of roll this up just slightly, this last little layer here. Gonna take my vet wrap, and I always make a little tail and stick it underneath my cotton or Ready Roll, and again, you always pull tight around the front and just roll around the back. And you want to hit about halfway and overlap just a little. Like Dr. Travis said earlier, she is a little dropped, so she's a little trickier to get wrapped. And then I'm going to go back up. like to try to always end my vet wrap at the top so I can grab onto it with my elasticon. Grab the tail of my vet wrap with elasticon, and again, we're going to do the same thing here. And the elasticon has little red lines, and we're going to overlap about halfway. And I'm going to come up and grab some of her hair so this bandage doesn't slip. And then I usually go one more just kind of in the middle and come across to end the elasticon on the outside. I'm gonna wrap some elasticon around the bottom. The important thing here I always try to do is get it kind of underneath her heel. Grab that hoof underneath. And then again, kind of just halfway. And get up on my bandage. And again, try to end on the outside. There you go.
Good job, Pistol.